were waiting. Intracystic biopsy. Intracystic biopsy, it's easy to perform. 19 gauge, very good biopsy forceps. You see that the diagnosis cost effectiveness is only 66%, so it's not 100. The histological concordance when you have an histology is 100%, so it works. The limitation is expensive, as everything, and you have more complication. And these complications are due to, if you biopsy everything, you will have complication. If you avoid to biopsy all the cysts, everything, you will have less complication and more interesting results. In fact, it's not recommended when the wall is very thin because of the risk of hemorrhage, because when it's thin, it's often serous adenoma, okay, so you have a big hemorrhage. And it's the risk of fistula if it's an IPMN with gastric, for example, not intestinal, but gastric type, because the fluid, you have no viscosity, and if you make a hole by your biopsy into the wall, because you have a communication with the main pancreatic duct, you will have a fistula. So avoid to do that, really. It's recommended when the wall is visible. When you have a real wall, you can biopsy. And you will have a cystic net, a mucinous adenoma, or a side branch IPMN with a thick wall, which is very interesting. It's recommended also in side branch IPMN with mural nodule when the patient is not perfectly fit for surgery. And you want to know if it's low-grade dysplasia and you can continue to follow the patient, or if it's high-grade dysplasia and even the patient is not good fit for surgery, if he's operable, you will operate him. So it's interesting in that case. Finally, it's Cellvisio, okay, you know, it's the best test for this diagnosis. It's the best, but only few teams are using it. For example, this is a large cyst in a young guy of 40 years old, and in the head, you don't know what it is, you do the Cellvisio, it's a serous adenoma, macrocystic, and you avoid to do a Whipple to a patient with a serous adenoma. You see this typical aspect with the red cells moving in this vascular pattern, which is totally specific as histology from here, the same cyst in an old patient, 17.7, and when you do, oh, sorry, how it works, yeah. I cannot play media. 1 hour ago, it was working, I'm sorry. Okay, look at this. This is the typical aspect of a serous adenoma on CT scan. You see, you have a lobulated lesion with septa enhanced with a central scar, and here you have the MRI. You can say it's a serous adenoma. If you ask that at the Radiological Congress in Chicago with 10,000 radiologists in front of you, they say, it's a serous adenoma. However, pancreas, it's more difficult than what we think. And when you do AUS, you see that it's not the typical of serous. You do a Cellvisio, and you find an IPMN. And you find an IPMN with a thick black wall, which means that it's highly suggestive of side branch IPMN, and in fact, of side branch IPMN with high-grade dysplasia, and the patient had a Whipple, which confirmed. And this lesion was typical of serous adenoma on imaging. So, what is important in IPMN is the risk of invasive carcinoma. This is a debate. I am a Japanese fan. These are what are thinking the Japanese expert. The European expert don't think that. Okay? They are changing their mind, but they are wrong. And they will discover that in 10 years. Okay, I see IPMN since 39 years. I am the oldest guy in the world seeing for IPMN. The first one was in November 1986. And IPMN has been discovered and described in June 1986, okay, by Professor Itai. So I have 40 years of follow-up of IPMN. And all the things which are said since 2 or 3 years by the European are totally false. These are what is said by the Japanese. In fact, look at this fantastic study of 1,500 patients followed for a big part, around 15 years in Japan. And if you look at this, when it's main pancreatic duct involvement, you see 40% cancer at 5 years, 80% at 10 years, 100% at 15 years. Everybody knows that. If you look at side branch IPMN, 33% at 5 years, it's accepted, everybody accepts that. 6.6 at 10 years, it's okay, but 15% at 50 years. And what is important, in half of this cancer are concomitant adenocarcinoma. They are not derived from IPMN. They are derived from PANIN. This is the difference between European and Japanese. The Japanese, they know that IPMN is only one of the precursors of cancer, and the other precursor of cancer is PANIN. PANIN is 80% of adenocarcinoma. IPMN is 20% of adenocarcinoma of the pancreas. That's the figures. In a patient with a family of pancreatic cancer, it's always PANIN which is giving the cancer, even you have IPMN. So in everybody, the risk to have PANIN exists. It's the reason why we have pancreatic cancer. When you have an IPMN, the risk is higher to have PANIN in the pancreas. You'll see the risk of ductal cancer in patients with side branch IPMN is 5 times more than the standard population, which means that when you look at the family of cancer, you accept 10% risk more than the standard population, 10 times. Here with IPMN, it's 5 times. Okay, so, and if you look at this side branch, less than 15 millimeter, in Europe, they say after 65 years old, you stop, follow this patient if you have no increase of the cyst. These are the new guidelines. It's totally crazy, since the risk increase with age. You have no pancreatic cancer, concomitant pancreatic cancer in patients with 55 years old or at 60 years old. It's not true. The patient are 75 years old when they have their cancer. They are 72, they are 80 years old. You understand? And if you look at this, at 15 years, you have 8% risk, 7.5 risk of cancer in this kind of side branch, less than 15. And 2/3 of them are concomitant adenocarcinoma. These are the Japanese answer. So, okay. Look at this. This is a patient, lady, 77 years old, follow-up, side branch, less than 20 millimeters since 17 years. AUS, I perform since 10 years every year. 3 years ago, small 9 millimeter nodule at the body-tail junction, CT and MRI done the same day, normal. AUS-guided biopsy show cancer, left pancreatectomy, cancer PT1A N0 M0R0, no recurrence at 5 years. This is our role. And of course, we have to do the biopsy. So why I finish by this, AUS should be preferred to MRI for the follow-up of side branch in patients more than 65, so the contrary of the European guidelines. CHAUS is the reference examination for the diagnosis of mural nodule. You know that the mural nodule is the more worrisome features, the more important worrisome feature. And MRI has a sensitivity of 44% only when it's less than 1 centimeter mural nodule. These are the results of the studies on MRI. And AUS is able to find them in 96%. Secondly, 10% of pancreatic adenocarcinoma are undetectable using most modern cross-sectional. But this 10% in expense center, this 10% involve 90% of PT1. 90% of PT1 are not seen on MRI or CT. And 30% of less 3 centimeter. 90% of these undetectable cancers are resectable in comparison with only 25% when CT and MRI find the lesion. These are the results. Okay, the diagnosis sensitivity of AUS-FNB is close to 100% in this kind of PT1 lesion. And finally, sometimes you see something on MRI, it's a stenosis, but you don't see the lesion. You see the stenosis and the dilatation upstream. And you do an AUS to find the lesion and to do the biopsy. So why to continue to perform this kind of MRI when finally you never find what is useful in the lesion, only the increase of the size of the cyst. So in conclusion, specific characterization, which means certain diagnosis, is mandatory each time that you discuss surgery. Avoid to operate serous cystadenoma. And each time that the diagnosis of serous adenoma is suspected, leading to shutdown follow-up. So when you say, oh, it's a typical serous, I will shut down, do an AUS and a sampling. And when you would say, oh, it's a typical side branch IPMN 5 centimeter, I have to operate it on, do also sampling. To establish the diagnosis of mucinous lesion, we have the clear communication, it's IPMN, the clear communication on MRI, or string test, or positive cytology or histology, or CEA more than 800, or positive NCLE, or specific KRAS GNAS mutation. You have the certitude it's a mucinous lesion. And to establish the diagnosis of serous, positive cytology or histology, or NCLE. These are the only certitude. When FNB is needed, is the key element during the follow-up of IPMN, because the risk of adenocarcinoma is 15% after 15 years. In patients more than 65 years old, the risk of concomitant adenocarcinoma not derived from IPMN is 7% after 50 years. Only AUS is able to identify and sample PT1 concomitant adenocarcinoma. This is true, and I thank you.